our senior colleagues who are here in this group today. So when I was asked to present, the approach to glaucoma is like, very confusing to say what exactly. If you say angle closure, okay, open angle, okay, trap, fine, AGV, fine. But, approach is little difficult to summarize. So what I thought is I'll just summarize whatever little small bits pieces I have learned till now in glaucoma and whatever major mistakes I have done. So we'll try to put up in form of few cases. So you can learn from my mistakes, okay, and how, like what all things I've adopted and what I'm doing now. So as to minimize the mistakes that I have done in the past and trying to prevent those mistakes recurring. So I'll be sharing my slides. No financial interest. These are my personal experience things. So there might be a little bit of conflict in the management plans. And most of the pictures that I have used in this presentation, they are all representative pictures. So please do not bother about right eye, left eye, spelling here, comma there. We'll just go to the exact case or the point that I'm trying to make. Introduction case. This case I had seen when I was first independent fellow of glaucoma. I was handling the glaucoma clinic independently without consultant supervision. So this happened to be quite a VIP patient with around 45 years of age. He had both eye good vision. His IOP was high in both the eyes, 32 and 34, and he was on multiple medications at presentation. So when he presented, he was on multiple medications, and he was also getting 3 Dimox tablets per day. So why I have used a patient in a wheelchair as an iconic photo is because of the side effect of this particular tablet, he was having a lot of cramps, pain, and other things. So he was literally bound to the wheelchair. He was brought in this fashion to the clinic. When we examined him, we saw that his angles were open. He had a large disc, which looked probably non-glaucomatous. His IOP was definitely high on both eyes. And I was literally confused, like what exactly I'm dealing with. So patient who has high IOP, no telltale signs of glaucoma, but IOP was definitely high, no disc changes. So definitely it was a recent onset high intraocular pressure. In glaucoma diagnosis, I was not sure. So what we can do, like my patient is already on multiple medications, so decided to add medication. I added the one which was not there in the list. I knew 2, so I started off with IV mannitol twice a day and added pilocarpine. What would you expect the result? The pressure control was temporarily better with mannitol, but again the pressure rose. It was later 42 and 46 within a few days. So then I thought that is going beyond my capacity. I thought that I'll take help from my consultant. So my consultant that time was Dr. Nikhil Chaudhary. He is still a consultant at LV Prasad, Hyderabad. So I thought I'll discuss with him because it was not going anywhere. So I thought, sir, this is a situation. I'm not going anywhere. What we should do? Okay. So I said one idea. I'm also not getting anywhere. So let's stop all the medications. It is a very suicidal step. But then we were not heading anywhere. The next step would have been TRAB. So we took a drastic step. We stopped all medications and observed the patient. Actually, this patient was admitted for observation. We didn't say stop all medications and go out. We had admitted this patient for observation, stopped all medications. And after 5 days of medication, the patient's IOP was 26. And after 2 weeks of completely off medication, his IOP was almost in normal range. So this is again a representative photo. Okay, so this was basically a simple, normal case of large physiological disc, which was misdiagnosed as glaucoma. And then patient was started on one medication. I don't know what went wrong. The patient's pressure shot up, second, third, and endlessly we went on adding medications and the pressure was never under control. It's an unusual case wherein the pressure sometimes can rise with medication. So whenever we are dealing with a glaucoma patient, we should be very judicious. First, sure of diagnosis, then medication, and then go not just go on adding medications. Sometimes there are cases wherein the disc is pale and we go on adding medications thinking that it will save whatever is remaining. It doesn't help. In case of any ION or pale disc, adding medications doesn't help. Patient is unnecessarily on medication forever. Another case scenario which has troubled me a lot. So the first case was, something which is once in a lifetime, a very rare thing. I would say, like, you can very well forget it. This was just to say that the approach to any case would be like, it's just with an empty mind. It can be anything. So we should be like, we should not have a preset notion that, okay, we're dealing with glaucoma, no glaucoma, whatever. So we should go to a case with a free mind, empty mind, and then see as per the reports, as per the behavior of the eyes, we should deal accordingly. Now, coming to the cases which we see on day-to-day basis, if you happen to see a disc like this, a right eye and left eye, there's a definite disc asymmetry between the two eyes. Okay, my little bit of experience, whatever I had in last few years, just taught me that first thing you should keep in mind is angle closure glaucoma. For diagnosing angle closure glaucoma, nothing like gonio, or without gonio, it is almost impossible. So if you have a case of a patient in which there is a gross asymmetry between the two eyes, always keep in mind angle closure. Do a gonio. Keep in mind angle closure could be there. Most of the time you will be right. Okay. Once you have like diagnosed that, okay, it is not angle closure, then only you go for other diagnosis. Most of the time it will be angle closure. So this is one major thing which I have learned. Make sure that lights are off, repeat if required, make the patient sit outside, do again. Once you have ruled out it's not angle closure, then only think of any other secondary diagnosis. Then, what if we are doing gonio for angle closure, sometimes gonio may throw up many other surprises also. Like at times I have diagnosed synechiae. If you see here, there's neovascularization of iris. Here there was a case of angle recession, which we had missed on history, and even the patient didn't remember that he had a trauma. In this particular case, you can see that the haptic of the lens was in the angles. In this particular case, there was a cortex which was hidden in the angles. So, and many more things, many more pictures to share if time permits. Like the thing to remember here is no technology can be a substitute for a thorough clinical examination performed by experienced ophthalmologist. And as far as we glaucoma specialists are concerned, gonio has to be done, and there's no escape for that. Glaucoma is something which has to be dealt with patiently with time. We cannot hurry up and just reach a diagnosis. Another case, I happened to see a 39-year-old male. He was having both eyes high pressure on 4 anti-glaucoma medications. His cup disc ratio was literally like okay, 0.6 to 0.7 as such. And this, again, IOP episode was sudden in onset, sudden IOP spike in follow-up visit. So again, representative picture, I was quite no problem. Pressures were high on second visit. CDR was okay. Gonio was open angles. We were surprised why this IOP spike had happened, because he had been following up for glass checkup, this, that had been going on for years. So we searched everything. There's nothing indicative of glaucoma. Then, but just by chance, if the patient never mentioned this to me, but this, I happened to elevate the lids while doing gonio and saw that there's something white mass over here. This was a bilateral injection of triamcinolone, which was given for something unusual. Like, I don't know why it was given. Even the patient could not tell. He said, yeah, some injection was given for eye trouble, eye pain, but there was no sign of uveitis or intermediate uveitis. Nothing was there. I'm not sure for what reason it was given. This was done in Bangladesh, not here. So, and we went ahead and removed this one. And once we removed this one, surgically removed the triamcinolone from the space, then the pressure came down back to normal within 2 weeks. Now, this is one unusual case, but then the steroid can be there in any form, in the form of inhaler, in form of skin ointments, in form of tablets, anything. And this is another common mistake that we do, that sometimes we overlook the possibility of usage of steroid when the pressures are high. So it's always important to think of common things first. This is a little uncommon case, but I want to make a different point altogether. This was a 48-hour repeat. Repeated it again, the similar finding. But if you look carefully, it is respecting the vertical meridian, and it is not. This is a red flag. If you have a HBF which is respecting the vertical meridian, always, it's better to be cautious. So we requested for a MRI, and they picked up a pituitary macroadenoma. Okay. So these situations can be life-threatening for patients. So whenever you have a vertical meridian, like vertical field respecting vertical meridian, you go ahead and either you refer the case or take consultation with a neurosurgeon or neurophysician, so that something major is not missed. In this particular case, it was interesting that after treatment, he fully recovered. since the patient was smart, he came early, he was diagnosed and completely recovered. This is unusual, but then keep in mind. Another case I would like to say, which has a similar thing, like approach is similar, wherein his 40-year-old male who had glaucoma. All the family members of this particular patient had glaucoma, but for this patient there was no positive sign. So I thought, like, let's keep a baseline HBF, for future reference, because I was highly suspicious he's going to develop glaucoma in coming years, because almost all his maternal side, paternal side, everybody had glaucoma. When the reports came, there was definite field changes. And the fellow who was there with me, he saw the reports and immediately wrote off, okay, start with iotim 2 times per day, this, that, everything. But somehow I had asked for a baseline HBF. Why is it showing change? That means I won't miss RNFL defect or a notch, which can create this kind of field effect on perimetry. So I thought, no, let's dilate the patient, check again what I missed. Okay, when I dilated the patient, there was something else which I was not expecting. So between my advice for the perimetry and the perimetry coming, the new event had happened. Okay, so this is just to highlight the things that whenever you have a report in front of you, please check again, cross check again if the reports are correlating, not correlating. If it is not correlating, repeat or go for the next test. Just on the basis of the reports, do not start the treatment. Track reports, see that it is correct eye, match, and then only you go ahead with the treatment. Now, just a few tips here and there. Like whenever you have a patient who is on glaucoma medications and you have problems like this, or this is one of my relatives who has started on glaucoma medication, he sent me the photographs. Whenever you have a side effects coming up, this patient was on brimonidine, and the kind of reaction that you are seeing on the lids and the excoriation down, why to trouble patients so much? Why to keep them on steroid drops and tell them that, okay, this happens, that happens. We have alternative medicines. If you just shift them to some alternative medicine, they will do better. And same with this one only. I just crossed over this medicine. He was on brimonidine. I started on prostaglandin analogs for this patient. This patient was on prostaglandin analogs, shifted him on brimonidine, and both did well in follow-up. Now, like any of the presentations is incomplete without surgery. This is my last slide, probably useful slide. So when I started doing glaucoma practice, these are all the complications which I had with glaucoma surgery: choroidal detachment, hyphema, hydrocorneal touch, and whatnot. Okay, so what I have learned with a small few years of experience is that whenever you're learning glaucoma surgery, please also learn one very nice technique of releasable suture. If you have this little tail releasable suture, it makes your life easier. Whenever you are operating, make sure that at the end of glaucoma surgeries, your AC is well formed. Don't think that, don't leave anything to chance that, okay, now it's AC is shallow, tomorrow morning by the time I open the patch, it will be okay. The next morning it might be worse and not be salvageable. So make sure that by the end of the surgery, you have a well-formed AC. If you want to leave a air bubble, leave it. If you want to take a releasable suture, 1, 2, please take it and make sure that AC is well-formed, because next morning you are going to see what exactly you have left on the table the previous day, or maybe a little worse also. So better to be prepared when you leave the case in the OT. Thank you.
Thank you very much, sir. We have learnt a lot from your presentations, the importance of good history, importance of gonioscopy, steroid responsiveness, how to carefully examine a patient before relying on investigation reports, retinal examination, how to carefully examine perimetry. I would like to invite Sugato sir has joined, the OSWB Chairman Scientific Committee. Dr. Sugato Paul sir has joined. I would kindly request sir to give your comments regarding Ravi sir's presentation. I think he's not online. Uh, we are very honored to have the OSWB President, Dr. Kajal Prasad Ghosh. Sir, if you are listening to me, can you give a few comments on the presentation, on the cases that Ravi sir has demonstrated to us?
Can you hear me? Hello?
Yes, sir.
Yes, sir.
Yes, sir. Yes, sir.
Yeah, excellent presentation. I have heard this presentation of Komarubi quite a number of times before. It's really wonderful, and it's a teaching to the glaucoma, especially the people who are entering the glaucoma practice, how to see and how to take care of all the reports and everything, and see again, so that you don't mistake. This is wonderful, wonderful case reports. I've heard it from Robi quite a number of times before. Thank you. It's wonderful.
Thank you, sir. Can we have a few comments or questions from our esteemed panelist, Surajit Da, Tamunas Da, Orijit Da? Would you care to comment or ask questions?
I have one question for Dr. Ravi. Yeah, the first case is really very interesting. So once you stopped all medications, the IOP came down. So it seems something had happened which caused the transient IOP spike that time. So once you have stopped that medication, by that time that effect went off and IOP came down. So must be maybe some steroid or any what I was thinking, bilateral Postner's Colesman, some rare entity, but sometimes we have seen those conditions, healthy disc, younger patients, bilateral IOP spike, rest for a few days, after that it comes down on its own. So do you think that may be a possibility for that your patient also, the first one?
There are two things in this case. We once everything normalized, all of us sat back in a glaucoma roundtable and then we discussed this case. So one thing that came up was, why not challenge this patient one by one with these drop and see what exactly is happening? Because in case of Postner's-Loschmann bilateral, probably once or twice in life he might throw up this kind of episodes again. So whenever he has, he might have similar episodes, but this particular patient never had any episode, neither in the past nor later, even when he was on follow-up. So we were a little bit doubtful about, it's possible, but if you say I'm not very sure, we thought of a paradoxical rise. If IOP, it is a well-reported thing, we thought, okay, it fits into that category. But again, if you ask me 100% sure, I'm not very sure. But what was my intention was to highlight that, the approach should be flexible. It should not be rigid.
Yes,
there was a point I was
trying. It was very interesting case actually. That's why I was thinking how it could happen. That's why it is very interesting.
Yeah. It's actually very interesting because there are some studies which have reported that if you use prostaglandins twice a day,
that's the thing,
or thrice a day, there is a paradoxical rise. So there are instances, but very rare. It was a very, very interesting case. Something to scratch your head about, because really, if you face something like that, you really are in a dilemma as to what to do right at that point in time.
And the team, I would say, the entire team of our glaucoma department at that time of LU Prasad was sitting there and discussed the case. So the possibility of having missed something is it's little low for being everyone, GC and Dr. Sirisha, Dr. Nitin, Dr. Mandal, everyone was there, and we were not sure. To be frank, it was everybody accepted that they are not sure. So what I'm trying to say is we should not be rigid ki, I will make a diagnosis. So sometimes it's no, we do not have a diagnosis. So we need to update ourselves. We have to have a scientific approach and learn and rethink.
And the depot steroid case was also very interesting. If the patient does not give a history, or you don't have records, there's such a large depot sitting somewhere in the superior temporal quadrant under the conjunctiva, you won't even think of looking. So that's something very easy to miss unless there is a history. So it's a very interesting case, very, very interesting case.
I'd like to know
hello,
from the
Ravida.
panel also. Yeah, please go ahead, please.
Yeah. I want to ask one thing to Ravida about the first case. Actually, I want to know that you said Diamox was also been given. So when you have seen the case from the beginning, it was been there, or you have started the Diamox?
No. I started the next two medications, pilocarpine and mannitol.
Okay. No, there's some, I have heard of that. I haven't seen till date. After application of Diamox, sometime there is rise of IOP, something like that.
Yes.
That is because of the mostly
choroidal effusion. Yeah, choroidal effusion.
Correct. So
don't know. Actually, I am thinking of that cause also. I don't know. I haven't encountered. I don't know whether in future I will have the same patient like that.
It's very unlikely that after stopping of Diamox and so many AGMs, the IOP has come down from 30 to 22. It's very unlikely.
Very interesting, Ravida. Thank you. Thank you very
Yeah,
much.
thanks for sharing this case. This is a very interesting case.
Thank you, esteemed panelists. Thank you, Ravi sir, for that wonderful presentation. Now I'll be handing over the podium to Prachi for the roundtable discussion. Prachi, you can take over.
Hello, I would like to welcome all of you, and I would like to thank Kumar Ravi sir for his excellent presentation. I'm sure all the youngsters will definitely benefit from it, sir. In fact, we are also learning, so it will be a huge learning curve for us also in the future. We'll also take home points from your presentation. Now, moving on to Glaucoma Roundtable, I would like to introduce Dr. Surajeet Sensei. He did his PG training from RIO Kolkata and Shankar Netralaya Chennai. He did his long-term fellowship in clinical glaucoma from SN Chennai. He was awarded with FAICO in subspecialty of glaucoma. He is currently attached in SN Kolkata. Dr. Arijit Mitra sir, he was awarded gold medal for securing high marks in DO examinations. He did his glaucoma fellowship under Dr. R. Ramakrishnan at Arvind Eye Hospital, Tirunelveli. Currently, he is practicing at Disha Eye Hospital. Dr. Avijit Paul, he did his glaucoma fellowship from Arvind Eye Hospital. He was awarded with FAICO in glaucoma subspecialty. Currently, he too is attached in Disha Eye Hospital. Dr. Tamonaj Basu, he was awarded gold medal for securing high marks in MS examinations. He did his DNB from SN Chennai. He did long-term glaucoma fellowship in clinical glaucoma from SN Chennai. Currently, he is associated with SN Kolkata. So let's begin our glaucoma roundtable session. My first question is for Dr. Arijit Mitra sir. Sir, what is your take on clear lens extraction for angle closure glaucoma? Because, yeah.
So the first, Prachi starts with the most controversial question, especially when you raise this issue in a glaucoma forum. It's sacrilege because glaucoma consultants do not consider cataract surgery as a treatment for glaucoma. But there was a lot of hue and cry with the EAGLE trial because it was a multi-centric trial. It involved a lot of different countries. And the results, they were very categorical. The results were that clear lens extraction is a treatment modality for angle closure. But when you looked at the study very closely, you could see that there were a lot of flaws. Now, this was not the first study which was done. Dr. Tanuj Dada and his group from AIMS had also done a study. So they also found some positive results. But what we have to remember is that the study has to be very properly formatted. And when you throw something like this out into the real world, things can become very dicey. So what we saw in the EAGLE study was that a lot of the cases, in a lot of the cases, the gonioscopy was not done at 36 months post-op. So the initial gonio was done, but the gonio later on was not done. So that was a very, very big issue. And the IOP drop was nothing very significant. There was just a marginal IOP drop. So the results and stats, they can be manipulated in such a way so as to project something. So it was projected as if, yes, clear lens extraction is a treatment for angle closure. But when we read the fine print, what we find is it's not really a treatment for all cases. Yes, probably in some cases where you have a large lens vault, where you have the effective lens position a bit anterior, you may achieve a dramatic lowering of the IOP and opening of the angle. But in most of the cases of angle closure, it is definitely not going to be very effective. So I would like to hear all the others' opinions on this. This is a very, very interesting question.
Surajit sir, I wanted to ask you about something related to the same topic. I read it in the EAGLE study that they did comparison between laser PI and clear lens extraction, and though they did not compare the visual field analysis post-operative. So what is your comment on that? Because significantly we see the visual field analysis is the main thing that tells the glaucoma progression. So
Yes. So the most important is that there are a lot of fallacies in this study. What Arijit just mentioned, that is the main part. Yes, glaucoma is all about the visual field defect, definitely, if it is progressing or not. But here we are trying to address the main pathology mainly in the angle closure disease. Mostly the lens is the main culprit here. We consider it always like that. It's a pathological lens mostly which causes this problem. But the thing is that there is nothing conclusive came out from this Eagle studies, and the conclusion what they have drawn, it is you can't rely on this if you just extrapolate it in your clinical practice. It is not possible. The main problem is there. So whatever conclusion they are drawing from this, the visual field changes, and they have definitely not documented that part also properly. So I can't rely on this study's conclusion. So I'll not change my practice pattern anyway with this study.
Okay. I want to know opinion of Dr. Tamunash.
Am I audible?
Yeah.
Okay, so like if we see about the Eagle study, they have actually the primary outcome was like the main quality of life. So if you are taking out a lens, which most probably is a hypermetropic lens in PSE or PSEG, so definitely the quality of life will change, will be better than PI. So that's the one thing. So they have mentioned the quality of life have changed. And the secondary outcome is IOP drop, which is marginally better, which is not like that all like good in clear lens extraction. And the third thing is that economic relief, but that was only calculated in UK most probably. So that also will happen because you are taking out the lens. So there is a drop in IOP they have calculated. But the main outcome they have mentioned is the quality of life. It has to happen. Like if you are taking out a hypermetropic lens and you are making the patient glass free. So it has to happen. The quality of life will be better than the LPI group. But that actually can't change the line of treatment because like clear lens extraction itself has many complications of its own. And there are results also, like there are many fallacies like they didn't do the gonio, they didn't have the HVF, but also like they have some fallacies in complications also. They have shown that the malignant glaucoma was there in 2 patients in LPI and no patients in clear lens extraction. That is like, I have done so many LPIs, but I haven't seen a single aqueous misdirection or something in YAPI group. So I don't know. For me, the treatment option will not change based on Eagle study, but definitely the lens extraction has a role. So if the IOP is little bit on the higher side and the lens is cataractus, I will just go ahead and do the lens extraction, but not the clear lens extraction, obviously. Okay. The phaco I can do if there is a little bit of cataract.
So one point I need to add, that definitely we can understand that this is one treatment option maybe. Okay. But the thing is that let there be little bit cataract at least. If you smell little bit of cataract there, you can bring down your threshold little bit lower. You can take out that if you are planning surgery like that. But doing through and through a clear lens extraction may not be helpful.
I want to add something. Hello.
Yeah, Vijay, please go ahead.
I am of also the same opinion what all the panelists said. What Tamna said that they have the 3 outcomes what he already said. One is that quality of life. Actually, after cataract surgery, contrast sensitivity usually improved. So they have shown that part. And the thing is that drop is not also that comparable. And other thing is that if it has been generalized, like it is the treatment of choice, then that will be an issue. Because in all over the world, if the treatment has been generalized, it will invite more difficulties, because doing a cataract surgery in phaco surgery who is not skilled, that will invite more complications. So I think this is also a problem. I think the study will be continued more, and they will take more steps. And other thing is that the requirement of TRAB, I think, in the PI group and the phaco group, that means a clear lens extraction group, also I think it's same. Arjita, am I wrong? Sure. The requirement of TRAB in these 2 group later.
Yes, requirement of TRAB is going to be the same, because you're not altering the course of the disease actually. You're just providing a temporary improvement in quality of life. Like Tomnash was saying. So when I look at a case of angle closure, there are actually 3 things you look at. Any angle closure. 1, you see the angle. 2, you look at the iris. 3, you look at the lens. So the angle, what I mean by angle is there are some cases where the distance between the Schwalbe's line to the ciliary body band itself is very less. That means the width of the angle is less in some cases. Number two is the iris, the curvature of the iris. And number three is the lens. So if I consider these three things separately, only the group where the lens is probably causing some effect on the angle closure is going to improve. The other two groups are not going to improve at all. So if you have a very anteriorly positioned lens, if you have a lens which has a very high lens vault means if you take an angle to angle bisector, the anterior portion of the lens which protrudes above it into the anterior chamber. So these cases are going to benefit. Other cases are not going to benefit. So if you routinely do an ASOCT and you can judge from these parameters, then a cataract extraction may be beneficial in some cases. Again, my initial thought is cataract extraction. I'm not talking clear lens extraction because it doesn't come to a glaucoma person to extract a clear lens. So it is an early cataract. Early cataract extraction, yes, you can consider. Otherwise, I think it's not a treatment option. Better to stick to PIs.
Okay. Okay, that was great, all of you. I would like to move to my next question. My next question is for Tamonash. What is the role of laser PI in angle closure glaucoma? And has the ZAP trial, which is the Zongshan angle closure prevention trial, altered your views on this?
Am I audible?
I
Yeah,
think
yeah.
the question is angle closure suspect, I think.
Yeah. Suspect. Yeah, suspect.
ZAP trial, they have included only the suspects.
Yeah.
So they have included PACS patients, and they have one eye control and one eye had like PI. And they have shown that there is not a significant improvement in disease progression with the PI. Like PI group doesn't have that much of benefit with the PI than the control group. What they have shown that around in the control group, there is around 7.97 eyes per thousand has progressed to PAC, only primary angle closure, and in the YAC PI group, it is around 4. So they have shown that it is not much, and like acute angle closure attack has only happened when they have dilated the patients regularly. So like we follow this pattern only. PACS, all the PACS patients, we don't do the YAC PIs generally. We like if there is a high risk cases, if the patient is not coming back for regular follow up or there is some retinal issues which needed regular dilation, then only we do a PI. Like if there is a like other risk factors are there, then only we go ahead and do the PI. This study also showed the same thing almost. Like nothing from my side which has changed, but there is a fallacy in this study. Actually, they have like excluded all the high risk cases. Whenever there is like a good spike in IOP, whenever there is a dilation, they have excluded those cases. So that can also give a bias. Actually, I would like to hear from others, but I follow the same thing whatever they have shown, that or I don't
would like to
do
take
YAC PIs on all the PIs.
Dr. Arijit's opinion on this.
Yeah, actually, I am of also same opinion. Actually, the thing is that in our country, if we follow this, that will create a little bit problem, because when I have seen the patient, I ask them, I am seeing the angle in 3 quadrant. One quadrant is little bit open. I am seeing PTM, but other I am not seeing with indentation. It's been opened like that. So IOP is not that much high. So I used to counsel them that I may ask you to come after 1 to 2 months. There may be chance of these, and I used to counsel them. This might be happen. There may be IOP rise, and this will be symptom. So most of the time, more than 50% of the patient are reluctant to come in so frequent interval. So in that case, I used to consider one thing, and if there is any retinal issues and retina to be examined frequently, I also prefer PI. And the thing is that if one eye is involved and other eye have already some issues like PSCG, then I used to do when I prefer laser PI. And when I in a gonio, even with low IOP, there is even normal IOP, I am not able to see the open angle. I am indenting and I am seeing the PTM. in 4 quadrant, then I used to do the PI. So actually, it's like that. I want to hear from other panelists also. Yeah.
Yeah, Arijit da, Surajit sir.
Yeah. So actually, this ZAP trial was a very bit surprising for me because of the big names involved, especially Dr. David Friedman. Dr. David Friedman has done extensive work on angle closure, along with Dr. Tin Ong. And this study being done in a Southeast Asian country, especially in China, Japan, Southeast Asia, the rates of angle closure are very high. But what their message was is this, that there have been previous studies which are hospital-based studies. For example, the study in India done by Dr. Ramanjit Siota, they did a 5-year follow-up, and their progression from PACS to PAC over 5 years was around 22%, whereas it was around 5% in this study. And the progression from PAC to PACG by Dr. Ravi Thomas was around 28%, which is a huge number over 5 years. So the progression noted in Indian studies is far higher than in the ZAP trial. Now, one of the reasons is this. One, the studies which were done in India, they are institution-based studies, not community-based studies. The ZAP trial was a community-based study. So they went door to door and screened around 11 or 12,000 people. Out of them, they found 889 or 900 people who were included in the trial. So that is one thing you have to remember. So that this is a community-based study, whereas all the other studies and the results are institution-based. So probably when a patient is coming to you in an institute, then you have to look at it more closely and do not blindly follow the ZAP trial, because it may be erroneous. Because when you're sitting in an institute, a patient who is referred to you or comes to you may have some sort of an angle closure. So don't rely totally on the ZAP trial. But the ZAP trial has said that probably we are overdoing PIs. So we should cut down on doing PIs. So which was a bit surprising. So it's a little bit, messages keep on changing. Earlier, there were studies which said that you should do more PIs. Now the messages you should do less PIs. But sitting in an institute, you should consider each case by its own merit, not just take that study with face value. So there is another trial called the LIGHT trial, which was on SLT. So that LIGHT trial was published, and the LIGHT trial said that doing SLT is comparable with drugs. But there's a newer study which was published in 2020, late 2020, which has refuted this claim. They have said that medications are better than SLT. So things keep on changing with time. So probably another study done in India will say something different.
I would like to add one small.
Yeah, I'd like to add one point. Oh yeah, please go ahead, please.
So there are a few patients of mine, okay, whom I had advised PI based on all the proper findings. They are a fit case for PI, but whatever standards you follow, they were fit cases. They had Sinecure also. Patients, somehow they didn't agree for the PI, and now they have multiple things, including retina cases, and they are dilated every time, like yearly thrice of 4 times in a year, and they have never had any angle closure attack. Sometimes I doubt my traditional knowledge also, that what exactly I'm advising, what's wrong there, like why they don't get attack, why they don't come for the PI. So it's like very difficult to understand. Somebody says you're doing less PI, somebody saying you're doing more. Unless until you have a conclusion, we would follow what we have been following, traditional teaching, that is probably the best as of now.
So I'll just add one thing, why this particular things happen is, like I said, there are 3 things: the angle itself, the iris, and the lens. So there are cases when a pupil is dilated. Then what happens ideally is that the iris tends to constrict. So that constriction of the iris depends on the elastic property of the iris. Just like when you talk about CCT and the biomechanical properties of the cornea, there are some mechanical properties of the iris. So that you cannot assess just by looking at the iris. So maybe, the crowding of the iris, that can be different, because the iris is like a sponge. It takes in water and it exudes out water when it constricts and it dilates. So the property of the iris is very difficult to judge. So probably what Ravi is talking about is, it's very difficult to judge. Maybe our clinical knowledge says go for a PI, but maybe in that case, you actually don't require a PI.
So 2 points to make here. The character of the iris, that is very important. There are studies on the ASOCT. They have seen that the iris characters are quite different in angle closure eyes. Most of them is a more thicker, more flatter kind of iris. And once they constrict, there is that spongy-like thing, peripheral thick iris rolls, and those configuration changes. Maybe those things are not there in Ravi's cases. That's why mostly he was not having those IP spikes. That is one point. I would like to emphasize on one point that Arijitda was telling that time. The study you are just saying, the 22% of PSC incidents, I think it is the Andhra Pradesh eye study that done by that Dr. Ravi Thomas that time. They followed up their cases, and most probably once they called them back after 5 years, they saw that a good number of patients had PSC. But the thing is that they could not call all their patients. There were very less number of patients, most probably around less than 100 patients they could call after 5 years. More important data came in the Chennai IDC study. This is the only incidence study till date in India. So they had called that almost 7,000 patients were included, and after that around most probably for the follow-up cases around 4,000-5,000 patients came there. There they noted that the incidence of PSC was around 1.1%, what is mostly comparable with the other studies outside in the different races also. Somewhere the incidence of PSC is 1.1% and the PSCG is very less, maybe around 0.2 or 0.3, I don't know exactly. Number of PSCGs are further lessened in 6 years. It was seen like that. So possibility of progressing to PSC or PSCG is definitely very less. The most important part of ZAP study was that we are overdoing the PIs. So definitely we have to keep this one. There should be the definite criteria for the young ophthalmologist. I would like to just emphasize on few points. Definitely in these cases, you can consider doing a PI. Like if the patient has one eye acute angle closure attack, other eye should be, fellow eye should be done. If the patient has strong family history, if you are seeing that there are patchy TM pigmentation, and the patient requires that patient complains of intermittent though colored halos, occasional those blurring of vision associated with some eye pain, headache, those symptoms are there. And specific cases like if it is subluxated lenses are there, in those cases you can consider doing the PI. Rest of the cases, be very judicious with the PI. It doesn't help much. So if you can follow the patient up, maybe every 6 months, if you can document your gonio properly, if you can follow them up every 6 months, then it is more than sufficient.
Correct. So I totally agree with Surajeet. Again, just that one point to stress that the Vellore eye disease, the Arvind Comprehensive Eye Survey, the Chennai Glaucoma study, all have said that at the community level, the incidence is very less. But when you're sitting in an institute, then you have to, judge each case by its merit.
Yes.
So like Ravi stressed before, do a proper gonioscopy and, evaluate your individual patient and then decide.
Yes.
And one more take-home message is like after PI, it's not over. You have to
true.
do repeated gonio after that. The disease can progress. That is a take-home message
Very
from
good
this
point.
thing. So,
very good one.
Thank you, everyone. I'd like to ask Ravi sir one question. Sir, would you start treatment in a patient of pre-perimetric glaucoma based on OCT findings alone?
Nothing. No treatment based on OCT finding. The finding that the diagnosis of glaucoma would be totally clinical, like exclude OCT. OCT is for documenting certain changes or what would happen in future, all those things. Okay, so pre-perimetric glaucoma, we will have to see what exactly is the status. If you are clinically sure of your diagnosis of glaucoma, okay, leave aside OCT, leave aside perimetry, you can start the treatment.
Okay, I want your opinion regarding OCT RNFL and GCL IPL complex also. So I read somewhere, sir, if we do macular GCL IPL, we need to do 10-2 in those patients to follow up or to confirm. What are your views on this?
I still am little traditional in my approach of glaucoma. Most of my progressions are diagnosed clinically. Like perimetry, yes, it helps, but OCT confuses me more than helping me. In very, very rare cases only, it helps me in concluding that okay, this is a kind of progression or no. Because what happens actually is sometimes the machine changes, sometimes the operator changes, multiple factors are there. Sometimes the signal strength is not there, and you being in a busy clinic, the only thing that you can rely on is your own eyes. Okay, doing a study, strictly following up one particular patient, going after that, okay, fine. maybe, but practically if you see, I have found it difficult. Oh, it's like, yes, we can go on like, discussing, debating all those things, but in the end, when it comes to a particular patient, what has helped me is clinical drawing, 10-2, what is happening over that. And OCT somehow it's like it doesn't fit my practice. Okay, I do it for documentation in certain cases, but nothing conclusive based on what OCT is telling me. I'm not sure about the practice of others. Would like to learn from them also. But for my practice, it is largely clinical diagnosis. Also, progression is clinical and with perimetry. OCT supportive, just to keep an evidence at what exactly is happening at something which my eyes cannot detect. But no, not something conclusive based on OCT.
Okay. Surajit sir, your opinion?
First of all, what I see that glaucoma has to be a progressive disease. That is very important thing. So whatever I am seeing, that whatever change is there in the disc, whether it is glaucomatous or not, that is very important. RNFL defect can come in other conditions also, like if you have in a kind of picture, if the patient had any acute stress or anything on the optic nerve, that can cause some RNFL defect. In high myopic patient, you can have some RNFL defects. We are not reaching the disc. So those are not very significant. So those things might be picked up by the OCT. So those there, that will show some red flags there, but that is not very important. First of all, I have to clinically judge that, okay, this is a glaucomatous damage, what I am seeing. Again, I have to see whether I'm dealing with an NTG or not. More than 50% NTG will not progress in their lifetime. So whether to start treatment or not, definitely I'll see multiple things, not obviously never based on a OCT finding. RNFL defects can be there from other conditions also. So first I have to confirm that. Only then I would prefer to closely follow up the patient. If there is some field defect is coming and definite progression, whatever I have documented already about the disc and all, if I have taken on a disc photo and all, if it is definitely progressing, definitely I will start treatment or change treatment. But just on the basis of OCT, never.
Okay, Arijit sir.
Yeah. So this question is usually asked because most people will not treat. But like Surajit mentioned, it's not just one factor, a lot of other factors. What is the IOP? What is the CCT? Is there a strong family history, etc.? So there are two things in every analysis. One is an event analysis. The other is a trend analysis. So even in the pre-perimetric stage, when you're following up a patient, either with the RNFL or with the GCC or the GCL IPL, you can do a trend analysis over time, even if everything is green. So everything is normal, but you can follow up the patient over 5 years and look at the trend. If the rate of loss, if you do a trend analysis, it will give you a rate of loss. Now, none of us do it. So I'm just talking from a theoretical point of view. But if a situation arises that this patient has a very strong family history and the IOPs are in the high teens, and I'm in a dilemma as to whether to start treatment or not, because the disc looks suspicious, but everything else is normal. So then I can opt for a trend analysis. If I see that that trend shows the RNFL loss to be much higher than I expect, then maybe I can go for treatment. Because there's this new concept which is coming. Because we as glaucoma specialists have learned that unless it comes on HFA, do not treat. So there was this recent conference, recent as in pre-2020, I've forgotten the year 2020. Before that, Dr. Harsha Rao, he gave this talk where what he said was that 30% structural loss occurs before you diagnose functional loss. That means it comes on HFA. But probably this is not true. Maybe the functional loss starts the day the structural loss appears. It is just that we don't know how to measure it. So waiting for something to show on HFA may not be the correct option. It is the correct option now, but it may not be the correct option in the future. Because if it was me, if I know that I have a very strong family history and I have a risk of developing glaucoma, probably I'll be better off treatment in the pre-perimetric stage. So demands are going to increase in the future. So if you have a machine which you can follow up a patient with and see the trend analysis, do it. Do a repeated GCC and see if there are any red spots developing in the GCC map. And then maybe you can treat. So I know I'm treading on very dangerous ground by making this statement, but that's how it is. Because technology is going to go by leaps and bounds, and probably something is going to develop where it will show a 1% RNFL loss shows on HFA. So maybe that day is going to come, but it's not now. So I agree with Ravi.
The problem
even after all the
is,
delay.
at the time we have a machine which detects a 1% loss, the data whichever we have collected over last 10 years will be redundant. There would be nothing to compare that. You would have a different baseline altogether.
Right. That's true. That's true. That's true. That,
I want
like
to
Ravi mentioned, biggest problem that I have is machines keep on changing. Every few months, earlier it was a RT view, now it's a spectralis, next it will be a ZEISS. So I have any data. All the maps are different each time the patient comes for a follow-up. Very difficult.
Okay, I want to ask Tamonash and Avijit, as they are yours. So I want to ask their opinion. What is their practice pattern basically? Let's get into this.
I also don't start any treatment based on OCT, but if I see any like thinning in the OCT, in GOCT map, like in superior or inferior quadrant, then I keep a red flag. I am very suspicious about it. I call the patient early. I just look again. I make the patient sit on the slit lamp and I look for any RNFL defect is there or not. But based on GOCT only, if there is any thinning there, I don't start any treatment. And for GCC and IPL, you have to be sure that there is no macular disease also. So you have to be sure that there is some other coexisting disease may be there. So that like for those also, they give red flags. So that thing you have to make sure that they don't have any macular disease or some other retinal issues. And then only we can like rely on GCC IPL. But for starting treatment, I don't like based on GOCT, I don't start. But obviously, if there is some thinning in the like suspicious part, then I become very like conscious and I ask the patient to visit more frequently. And I
okay, Avijit.
Yeah. Same thing as other panelists says. The thing is that same for me. I don't also start treatment for those. But what Arijit said, if there is a family history and some disc change, like little bit focal thinning, which I can't cut in HFA or something like that, I little bit suspicious for those people. So I ask them for frequent follow-up and frequent test. Then I go for actually I haven't still treatment in such kind of patients. I always ask them for frequent checkup. Always I wait for the functional loss to be detected, like in HFA. Still to learn.
Waiting
for. Yeah.
Because of the time crunch, I'm going to move on to our last question. So my last question, anybody can come up with answers. Basically, this is directed and because it's for yours, young ophthalmologist. So I want your opinion for the role of pachymetry in glaucoma management. Do you do pachymetry in every patient, or you wait suspecting if the patient has ocular hypertension in that category, then eventually go and do ECCT, or you have made it a protocol that you will do HVF and pachymetry in all the patients? Anybody can come up. I can see you disagree.
Once the patient, no, not disagree. Definitely, I agreeing it. Once the patient is diagnosed with glaucoma, we have to see we do it the central corneal thickness. Definitely. Once the patient is diagnosed with glaucoma, definitely. If the patient has any borderline IOP and all, anything, we'll definitely do the central corneal thickness. We'll definitely do it. It is very important in that way. Now the question is how important it is. The question, most important part, it is there. I think one landmark study that gave most importance to this pachymetry, that is the OHTS. They told that if the patient has thin IOP and higher thin pachy and higher IOP, there is a highest chance of progression to glaucoma. So that is the most important part we have to keep in mind. We are dealing with ocular hypertension. The patient has thin pachy, and with that the high IOP I'm dealing, I might be more prone to start treatment for that patient. That is one important part of pachy in those cases. Now, if it's a diagnosed glaucoma patient, not ocular hypertension, it's the glaucoma patient. Now I am seeing that patient. There I have to consider many other factors. The pachy is the one of the factor definitely to set the target IOP, definitely. And also that along with that, we have to keep this thing also in mind that the pachy, it has been seen that if the central corneal thickness is less, they are more prone for progression. There are many papers like that. They have shown, because there are some changes in the lamina fibrosa also. That is correlates that the thinner Pachy has some changes in the lamina cribrosa also, so they can progress more. There is a possibility. So I become bit more suspicious when I'm dealing with a thinner Pachy. If my known glaucoma patient, I'm following up. If I know that the patient is in thin Pachy, then I will be more. I will definitely keep that thing in my mind that this patient might progress. So this way, Pachy helps me, but it is not that I am going to change my practice pattern anyway. The patient is having Pachy of something, and I'm dealing with the whether for this IOP and that IOP, I'll change my treatment immediately. It is not like that. In selective cases, what I had mentioned in few of these conditions, I consider the central corneal thickness. Arijit Da, please.
Yeah,
Sir,
actually,
now, sorry,
now,
sir. So to cut
yeah,
you in,
yeah.
I had one question
Uh,
related to this one, the same thing only. So, do you repeat Paki after few months or 1 year or so follow-ups?
So it is seen that if the patient is on prostaglandin analog, that is the one thing. If the long-term use of prostaglandin analog can cause a change in central corneal thickness, otherwise it is not that much important.
So what they usually recommend is repeat a Pachy every 5 years. Before that, it's not necessary. So 5 years is a pretty good time. And now all the nomograms and all that you have, so you have a lot of nomograms where you have a 10 micron increase with a 0.7 or a 10 micron increase with a 1 decrease or an increase. What they're saying is all these nomograms are not true anymore.
Yes.
So Dr. Francisco Buni and all the others, what they are saying is treat Pachy nowadays like you treat age. For example, if you have a person of a certain age, you don't add or subtract anything to the IOP. So what you just note is whether this person has a thin IOP, that means a greater risk. A thick IOP means a lesser risk. So that is the only way now to approach Pachy. The reason why they say this is that the relationship is not linear. That means CCT is just a value. So based on that value, if you add or subtract, that's not correct, because the cornea has a lot of other properties, which are biomechanical properties. So CCT is just a number. So kind of subtracting or adding something to the IOP based just on CCT is not correct. So the EGS has also now tried to do away with CCT and the nomograms. So CCT is very, very important. Do CCT for each and every patient. And you just know the risk. That's all. Like Surajeet was saying, because what you have is the thickness of the cornea has a correlation with the lamina cribrosa. So if you have a thick cornea, it has a thicker structural support at the posterior part of the eye, where the axons are exiting. So that person will have less damage due to IOP fluctuation. So nowadays, people are stressing more on IOP fluctuation rather than on IOP per se. Because if a patient has 28 millimeters of IOP, let's say there are two patients, one 28 with a IOP fluctuation of plus minus 4, and the other 28 with a IOP fluctuation of plus minus 8, then the person which have more fluctuation, that's plus minus 8, is more prone to damage. Because the lamina cribrosa will keep on bending and stretching. That will cause damage to the axon. So if your CCT is higher, you have more structural support, less damage. So just use CCT as a marker for lower risk or higher risk. That's all.
What I usually do is,
Abhijit and Tamunash? Oh, yes.
Yeah,
Sir.
same
Yes,
opinion.
Yes,
KRV
sir,
sir.
continue.
KRV sir was saying something. Dr. Kumar
Yeah,
was saying.
Ravi?
we follow the pattern is in the first visit, if I suspect that, okay, it's a kind of a glaucoma patient or glaucoma suspect, I advise for Pachy and note this number on the file first page. So any of my patients, if you see the first page, there will be a Pachy value. If there is a slight suspicion, family history, glaucoma, and if the patient is on prostaglandin analogs, every 5 years you need to repeat. I done a short study also on this patient, on these patients who were on PG analogs for 5 years. I found that the value decreases by 5 microns in 5 years. So there could be a fluctuation, or maybe 5 is something which could be variability also. But then after 5 years, I do repeat the Pachy's. And I would agree with what other speakers have said, especially Adijit, that it's just a number. We have to keep in mind whether the risk is high or low. Usually, we don't go for correction of IOP based on the Pachy values.
My patients also, whenever I advise HVF for the first time, or whenever the patient is coming, I get a Pachy. But the Pachy value is there, but I don't follow any nomogram. And if it's thicker, then like I assume that it's I am getting a high IOP because of that only, but I don't change any treatment based on that. So that, but I get a Pachy value, like for sure. I have that thing in my patients.
Hello.
Yes, yes, please.
Yes, sir.
Yeah. Actually, I want to stress on that point what Arijit said. Initial days when we were learning glaucoma, still to learn, we try to add the number following the nomogram. For the PGs, it is important that now it is to note that whether I am dealing with thin CCT, thin central corneal thickness, it is a risk factor. So I think it's not needed now. I don't follow it now. This is an important point. And what Surajeet said, and the landmark studies, OSTS and EMGT also said something about that. OSTS saying that thin CCT is a risk factor for progression to POAG from OSTS, and also EMGT, early manifest glaucoma trial. They also are shown that there may be a chance of progression in thin cornea. So initially on the first, when I'm suspecting that might be a glaucoma case, I used to do a Pachy, and that repeating Pachy, it's same what all the seniors said.
Okay, before concluding, I'd like to ask Dr. Sugata sir. Sir is about to leave and join the next meeting. Sir, we'd like to have a word from you, please, sir. If you're still here. I think sir has left.
I think sir has. Sugata sir, can you just give a final comment before joining the other meeting? And would you like to invite the speakers and panelists for the next meeting? Okay. I think sir has disconnected. Shivasish, would you please give the final note?
Thank you, everyone. It was a lovely meeting. Our team of YOSI West Bengal, we planned this CME for glaucoma to discuss the important issues and to help the young ophthalmologists approach a case of glaucoma properly under the guidance of Dr. Ravi sir has explained us wonderfully how to approach a case. I would also like to thank our chairman, sir, Dr. Surajeet Sensei, our esteemed panelists, Dr. Arijit Mitra, Dr. Tamannas Basu, Dr. Abhijit Paul, and the session was wonderfully moderated by Dr. Prachi Subedar Ghosh. So it was a wonderful session. Thank you all for joining us, and we had such a lovely discussion on such important issues on glaucoma. So I think it will help all the young ophthalmologists to approach a case of glaucoma in a more scientific and in a more logical way. I would like to wrap up this session a little fast because OSWB has a district outreach program which has started from 8 p.m. I would also like all our esteemed panelists and our young ophthalmologists who have joined us in today's session to it will be great if you also join for the district outreach program in the case presentation series. It is also a lovely case presentation series which is going on every week. Thank you everyone for joining us this evening for this wonderful session. It was a wonderful interactive session, a little different from what we do, but I think we can follow this pattern in future also. Thank you.
Thank you so much. Thank you so much for having
everyone.
us.
Thank you. Thank you.
Thank you, everyone.
Thank you. Thank you, everyone. It was a lovely program.
Thank you.
Okay. Bye-bye.
Bye.